Learning Exchange session. And welcome to the sixth lessons webinar. So for this webinar, we'll be focusing on PPR and gender equality and human rights. And we have very well-qualified speakers and resource persons for you today. So we'll have Dr. Emilomo Ogbe from the Global Fund, who will share about PPR and gender equality. And we also invited our colleagues from ACT Africa, who developed community guides on human rights and gender. So Lessons is actually a component of the Communities in Pandemic Preparedness and Response Knowledge Hub under the Copper Project, implemented by the Activist Coalition on TB Asia Pacific, hosted by APCASO. It's also hosted by the Africa Coalition on Tuberculosis, or ACT Africa, and the Regional Learning Hub of Anglophone Africa. And of course, this will not be possible without the support of our colleagues from the Global Fund. So this will be our guidelines for the webinar. So as you can see, the session is being recorded so that we can share it with other participants who may not be able to join us asynchronously. And we also request that you change your Zoom name to the specified format. So you can put your name and then your pronouns and then the organization that where you're coming from. So I see on the chat that there are some people who are already introducing themselves. So if you can add your organization in your name, that would actually be very helpful, especially during the Q&A portion later on. And of course, we also want to make sure that everyone can hear us clearly. So if you're not speaking, kindly mute your microphone. And of course, it's also preferable that you turn on your camera so that we can have an engaging conversation. So I see some of you are already turning on your camera, so that's really good. And if there are still others who want to turn on their cameras, that's better. And of course, you can also use emojis, or you can also use the raise hands function in the Zoom if you want to interact with the speaker. And if you have questions, you can also utilize the chat function. And you can use that for comments, for sharing your insights. And also, if there are technical difficulties, kindly let us know. So right now, the session is being conducted in 4 languages. So we have translations in English, we have a translation in French, in Khmer, and Bahasa Indonesia. So let's also try to make it a safe space. Let's try to respect each other's opinions and insights. And as always, questions are very welcome at the end of the session. So if you want to transfer to the other channels, so you can look at the icons, the interpretation icon at the bottom part of your Zoom, and then you just select the channel that you're comfortable with. So now let's proceed with some icebreaker before we proceed to the meat of the discussion. So let me show you this whiteboard. So some of you probably this is the first time that you're seeing this whiteboard. So it's a new function in Zoom that we're trying out so that we can get more participation from our audience. So even if you're an individual participant, you can use this in your desktop or even in your phones if you're joining us using your mobile. So we'd like to know first where you're coming from. So you can probably zoom in. So on the bottom right hand of the screen, you can zoom in or zoom out the whiteboard. And from here, I'd like to request people or our participants to use the stickers or the emojis here to show where you are. So for example, I'm calling in from the Philippines, so I'll put a heart here in the Philippines where my country is located in the map, just so we have a sense of where people are coming from. Okay, so some of you are moving the slides. That's fine. So if you can just put stamps. So if you want to show the emojis, you can either click the smiling icon on the left hand of the screen, and then you click your preferred stamp or emoji, and then place it where you're coming from or you're calling from. So I see someone placed what's this? A thumbtacks. So probably we just need to move it a little bit. Okay. So I see some people are calling in from Asia. Okay, so I'll just need. Okay, some people are calling in from Thailand. And of course, as always, if you're having challenges with this application, you can put your answers in the chat box. Chat box. So as I can see here, someone is calling from Kenya. We have participants calling in from Ghana, from Kenya again, from Sierra Leone, from Ghana. Okay, so if you're having challenges, no worries. You can just type it on the chat. That's fine. Okay, some of you are typing Ghana. Okay, so you can either type or use the emojis. Okay, I see here someone is calling from, where is this? Indonesia. Okay. In the probably the western part of Indonesia. Yeah. We have someone use a sticky note here. They say they're from Nigeria. Okay. Okay, and people also dialing in from Cameroon and from Cambodia. Okay. So it's a good mix of participants coming from different countries in Asia, Southeast Asia, as well as Africa. All right. So now I'd like to invite you, since the topic is focused on gender for this webinar, I'd like to get your ideas on this question. So when we talk about the concept of gender, or when we hear the word gender, what comes into our minds? You can type here a phrase, a word that you usually associate with gender, so that we have a starting point for discussion, since most of our speakers will share a lot about gender issues later. So I see someone typing on the chat. And again, you can still use the chat function if you're more comfortable doing that. So I see here, someone typed in, everyone has SOGSC. So SOGSC is sexual orientation, gender identity, expression, and sexual characteristics. All right. So of course, we understand that gender is a quite a complex phenomenon, especially for some people who are just hearing about it for the first time. So we might need to also unpack that a bit later. Okay, someone typed here differences, specificities. So they're still typing here. How about on the in the chat? What are the things that you think of when you hear the word gender? And I think one of the things that we need to underscore when we talk about gender is that everyone has their own SOGSC, not just people who identify as part of the LGBTQIA plus community. So Collins here said gender is an adjective describing roles each of us admire. All right. And someone typed here the social construction of being male or female. And of course, we know that that will have implications, especially when we talk about pandemic preparedness and response. Okay. Anyone else who has inputs about gender? Okay, so I see here some people who are still, I think, trying to figure out how the sticky notes work. And here, Omotayo said, gender refers to the social, cultural, and behavioral characteristics that are associated with being male or female. Or some people would also classify themselves as non-binary, right? So they wouldn't identify with a specific gender. So that's also part of conversations on gender. All right, so I think we have an exhaustive list of concepts related to gender. So now I'd like to invite you to go back to our main topic for this session. But before anything else, I'd like to just emphasize again that Lessons is a series of webinars that are tasked to empower participants, particularly civil society organizations, on knowledge related to pandemic preparedness and response through lectures from resource persons and knowledge exchange activities with country implementers. So we have a website where you can view previous sessions. So we have lessons 1 to 5 already uploaded. So this will be the 6th webinar that we're conducting. And also you can use this QR code to go to the website. And then we also have a YouTube account. So if you want to view them from YouTube, you can also do that. And the last session was already uploaded. And I'm also sharing this resource material. It's called the PPR Guide for Communities. So if you want to read up more on how we set PPR engagement priorities, how we create meaningful engagement in joint external evaluations or in the state party self-assessment annual report, or in the creation of the National Action Plan for Health Security, then you can also visit this resource material. And we also have a PPR training module to increase the capacity of human rights and advocacy in the context of pandemic prevention, preparedness, and response. So you can scan this QR code or click on this link, and it will take you to the copy of the modules. So now, before we proceed, I'd like to turn it over to the coordinator of ACT Africa, Rachel Otu Amponsa, to give us a welcoming message for the webinar. Over to you, Rachel.
Thank you very much, RJ, and I hope everyone can hear me loud and clear. So as RJ stated, my name is Rachel Otu Amponsa. I am the project coordinator for the Copper CE, and I work with the African Coalition TB ACT Africa, one of the regional network implementing the Copper CE project in 5 African countries, that is Kenya, Liberia, Nigeria, Sierra Leone, and Cameroon through our country partners, in addition to 3 countries from the Asia Pacific region, that is Cambodia, Indonesia, and the Philippines. So again, I am delighted to welcome you to today's webinar, where we'll be delving into the intersections of gender equality, human rights, and PPR. And I'm also excited to announce to you that today we are launching our compendium on community guides for PPR with different thematic areas. Really excited about that. And so throughout today's session, I would encourage you to engage actively, whether through questions, comments, or reflections, as we aim to foster a meaningful conversation that can lead to a practical and lasting effect. So thank you once again for being here, and let's dive into the discussion. Over to you, RJ.
Thank you, Rachel. And now we go now to the introduction of our speaker for tonight. So just to give you a background of our speaker, so Dr. Emilomo Ogbe is a medical doctor and a researcher with expertise in gender mainstreaming, bioethics, sexual reproductive health program management, policy analysis, and research in West and East Africa and Southeast Asia. So she was formerly the director of AISE Consulting Global and a researcher at the University of Ghent. So she was also a consultant for the Department of Reproductive Health and Research in the World Health Organization Geneva, and the project coordinator for an EU FP7 project focused on postpartum maternal and infant health across 4 sub-Saharan African countries at the International Center for Reproductive Health, University of Ghent, Belgium. So currently, she serves as the technical advisor for gender in the Global Fund. So without further ado, I'd like to introduce to you Dr. Emilomo Ogbe. Over to you, Emiloma.
Emilomo, you're muted.
Can you hear me now?
I think there's just
Yes,
an
but there's an echo, so
yeah.
maybe one of your machines needs to be switched off.
Okay, can you hear me now?
Yeah, I think that's
Yes.
better.
Okay, fantastic. Sorry. So good afternoon, everyone, and thank you, RJ, for that introduction. It's a pleasure to be with you here. And today we're going to be discussing gender human rights considerations within pandemic preparedness and response. So I was very excited to just kind of look at the comments that were coming back during the icebreaker session about the definitions of gender. And some of those things we're going to discuss as we talk about risk as well as response and potential strategies. Just the same for this, while I come in to this meeting with my gender expertise, I'm really looking forward to hearing your reflections and comments from the work you do on the ground on pandemic preparedness and how some of these concepts we're going to discuss are directly applicable to you. I will also be talking about some references from some of the excellent work that is being done by the COPPER team on a scorecard and also the considerations guidelines that Rachel is going to speak more about later. So I'll start with the slides. In between, I might stop and ask a few questions to try and get some reactions from you. So even though I can't see all of you, I know most of your cameras are off, and in presentation mode, I won't be able to see you. Please feel free to raise your hand and put a thumbs up. Put on your camera if you want to share any reflections or you have any questions, in case I can see your questions in the chat. Okay, so thank you. And as RJ said, I'm a technical advisor on gender. I won't go into another introduction as he's already introduced me. So we'll start the session and the presentation. So please, the next slide. This is just an outline of what we're going to be talking about together today. I'm going to go back to discussing what a pandemic is. I know I'm in a room with experts in the communities on pandemic preparedness, but just going back to thinking through what is a pandemic and its impact. I'll talk about a framework which some of you might be familiar with or not familiar with, which kind of looks at not just gender, because right now I'm not only talking about gender, but also human rights consideration within pandemic preparedness and how our different intersectional identities can influence our risk, our vulnerability, and the types of response we need to take into consideration. And then I'm going to present some case studies, and this is just kind of going down into at the community level. What does this mean? What's the impact of pandemics like COVID-19, and how have communities responded in their own resilient, innovative ways to some of the challenges by using a gender human rights intersectional approach? And then there'll be time for reflection. To the next slide, please. So I am not an expert in pandemic preparedness, but I have a lot of experience working on gender and public health. And so for me, it was good to go back to the definitions and talk about the differences between a pandemic and an epidemic and why COVID-19 was such a big issue. And so COVID-19 or any other kind of pandemic, for example, the bird flu or an influenza virus, are viral respiratory or other viral respiratory diseases are the ones that cause a strain of an existing disease which spreads worldwide. Epidemics tend to be centered around a certain region, but pandemics tend to have global impact, and that's why COVID-19 was such a big issue for all of us. By the end of 2021, the COVID-19 pandemic had resulted in over 246 million cases and 5 million deaths worldwide. And there were the deaths and there were the public health implications and morbidities, but the economic and social disruption was also devastating. In 2020, the World Bank cited as saying tens of millions of people were at risk of falling into extreme poverty. while the number of undernourished people, estimated at nearly 619 million people, were expected to increase by up to 130 million by the end of that year. And why this is important for gender and human rights considerations is also because when things like this happen, when there are public health, when there are pandemics, when there's a public health impact, when there's disruption to social and economic structure, people who are most vulnerable are most affected. The next slide, please. I see Leng, you have your hand up. Do you have any questions, or did you want to share anything? Okay, I see RJ says I should go ahead, and then we'll have a reflection afterwards. So in terms of thinking about what are the gender and human rights implications or considerations in the pandemic preparedness, we thought it was useful to have a framework. Now, this is just a framework. In different communities, in different contexts, parts of it might be more applicable than the other. But it helps us think about who is most affected, who are the people, and not just looking at gender, for example, in terms of male, female, gender diverse, but our intersectional identities, how different things around our ethnicity, coexisting morbidities, in some contexts, things around like, are you indigenous, racial, sexual orientation, class, wealth, affect access to resources, makes you more marginalized, and makes you more vulnerable to some of the impacts we discussed. The advantages of using this gender human rights intersectional lens helps us, number one, tailor interventions that are relevant for the people we want to serve. People are different, they have different vulnerabilities, they're different marginalized groups, and having a generic public health outreach program that doesn't take into consideration some of these different vulnerabilities, the different needs of marginalized groups, can sometimes do more harm than good. And so in this bill, which is a very useful way of kind of thinking through some of these different intersectional identities, you see we've put things around disability, age, sexual orientation, ethnicity, race, in context where people might be illegal migrants or migrants or citizen, income, class, all those things can impact, all those intersectional identities can impact your experiences of a pandemic and some of the impacts we talked about, the social disruptions, the public health impacts, and some other issues. Now, I'm going to draw upon an example that is in the considerations guide that Rachel will talk more about. For example, in certain contexts, we know a lot about that during COVID-19, a lot of women had to stay at home. In many contexts, globally, women tend to take, especially women who have children, tend to take part-time jobs. So they lost their jobs quicker. So they were at home most of the time. They had increased care burden for taking care of the children. And in homes where there was already a history of abuse, gender-based violence rates increased and soared. That's just one example where we're talking about gender. We're talking about economic opportunities and ability and the intersections between, are you a carer or not? Do you have children or not? What is your economic status and experience of abuse? So if you had a public outreach program that was focused on wearing masks or, for example, washing your hands, and you didn't think about some of the considerations or some of the impacts it had on these populations, on women who were at home, who had to lose their jobs, who had increased economic insecurity, and they were experiencing gender-based violence, your public outreach would have been effective. So those are some of the considerations we need to take into account as we develop interventions. Please go to the next slide. Thank you. And the next slide, I'm just going to go through some of those examples that I have shared. I talked about women who were mothers, but also thinking about children. COVID-19 and the pandemic and the responses. I'm using COVID-19 because it's the most recent experience, but of course we've had other pandemics and probably we will have others in the future. So I'm really looking forward to having that reflection during the Q&A session. But for the case studies, I've focused on COVID-19 because it's the most recent example that we have. Now, because of the lockdown measures, the right to education was impacted for a lot of children. Now, think many children couldn't go to school. The impact was not equal globally across all contexts. This was also affected depending on, are you from a lower socioeconomic class where you're attending a public school in a developing country where there was no opportunity for virtual classes? Those children were impacted more than others. In some contexts, you also had issues around girls. There's a lot of documentation around girls from a lower socioeconomic class not being able to access educational services. And when we start talking about other intersectional identities around disability, race, sexual orientation across different contexts, you start to see how these considerations are important about thinking through these issues. I bring back gender-based violence again and child marriages in 2020s. In a context where people are already, for example, of a lower socioeconomic class, are experiencing extreme poverty, the pandemic made them even more vulnerable. Child marriage became justified as a way to to improve economic situations for many families. So there was an increase in child marriage, there was an increase in gender-based violence, and as I said, women bore more of the care burden than they normally do. And then when we start to look at even vulnerability to risk, as I said, when we talk about gender, we're not just talking about women, we're talking about how it affects men, women, gender diverse populations. And also when we integrate human rights and an intersectional identity, we think about all these different intersectional identities. So we see that even men were more likely to experience hospitalizations and deaths than women for biological and gender reasons. For biological reasons, because of the way the SARS-CoV-2 virus binds to a particular enzyme found in the blood vessels of men that are at different levels with that of women. So they were more vulnerable. But also toxic, harmful norms around masculinity. For example, I'm too well to go to the hospital for a routine check. Men in some situations and in some contexts are more likely to engage in certain harmful behaviors. Again, some men, not a stereotype, but some men, because of harmful masculine norms, have lower rates of hand washing, higher rates of smoking and alcohol misuse. There are comorbidities that lead to increasing vulnerabilities. So if those masculine norms or those harmful gender norms in certain contexts were not addressed, you can have a public outreach program. You can talk about broad hand washing, checking signs and symptoms. You can list the 6-7 symptoms of COVID-19 and say, go to the hospital. But if those harmful norms are not addressed, or if you don't use a gender transformative approach or responsive approach, then you miss people, because you have the same people going to the hospitals. Men are less likely to attend and are only likely to present when they have complicated symptoms. Next slide, please. Now, moving from that context, now talking about a global context and human rights issues around things around, for example, race. So in many contexts where, for example, race, ethnicity, or your identity around socioeconomic class influenced access to resources, we saw very differing rates of morbidity and mortalities. Morbidity meaning complications of the disease and some of the symptoms and presentations. Mortality meaning number of deaths were very different across different populations across the world. Even in more developed countries where there was access, quicker access to vaccination and preventive treatment. And then when you start to talk about, for example, key populations, in many contexts, in different contexts across the world, these are populations that don't have direct access to resources because of stigma. And when I talk about key populations, I will list, for example, men who have sex with men, transgender communities, sex workers, female sex workers, male sex workers, injecting drug users, women who use drugs, people who use drugs, even migrants and internally displaced persons who, on a normal day without a pandemic, have difficulties accessing comprehensive quality care without any stigma and discrimination. Now, during the pandemic, there was disruptions in some of the drop-in centers and facilities that were available to them, meaning that there were declining test rates for some of them. Many of them couldn't access these services, and there were disruptions. So, meaning that population, that group was also more impacted by the pandemic. So, these are some of the examples we're using to kind of illustrate how if an outreach program is done as an emergency response in any kind of pandemic or long-term public health planning is done, if that intersectional lens, thinking through, are there certain groups of people looking at gender, looking at rights, access to services that are impacted differently, and creating tailored programs? They're not always possible, of course, depending on the budget and the ability, but putting some nuance into some of the outreach programs. How do we reach people? Where do we reach people? What are their vulnerabilities? How are they impacted? Can make such a difference in developing a comprehensive response, especially for communities who lead advocacy efforts and are able to advocate to the governments or the people around them or lead community-led monitoring efforts. To the next slide, please. Now, in thinking through this, we're thinking, how do we, I have said, I don't know, but working in my field, sometimes I get feedback sometimes that, okay, yes, let's integrate gender and human rights. How? What do you mean? I mean, there is so much I can do. Like I've listed many impacts, many case studies, many problems, from girls' access to education to access to services for gender diverse and key populations. Where do I even start? And so our team was thinking of, what are the entry points? As a community member, as an advocate, as someone who is involved in public health response efforts, or even in advocacy or community-led monitoring, how do I start to make an argument for integrating or using gender and human rights? When I start thinking about my advocacy, intervention, or community outreach activities, what are the levers, what are the entry points to start to understand, how can I start thinking about gender and human rights in a concrete way, in a way I can explain to the person next to me, in a way I can explain to my policy makers, my community leaders, my health authorities, so they can go along with me when I start to do my advocacy. And we've listed some of them. They are not exhaustive, but they're entry points to start the conversation. Almost every disease, biologically, so we're not talking about gender, but many illnesses do have sex differences. And then when you overlay that with gender, so the social construct, the expectations around behavior, the socioeconomic vulnerabilities that come with being of a different gender, the behaviors that are sometimes harmful and sometimes protective, your vulnerability to disease is always affected. So thinking about exposure and severity, you're already talking about gender. As I gave an example with the differences in morbidity and complication of disease between men and women. And then when you start to talk about KP populations, just the fact they don't had disruption to access of services mean they will be more vulnerable. Then access to prevention and treatment information and services. Again, this is affected by your gender. In many public health institutions, most times women will have more access because they go for antenatal care. But even then, we're talking about a certain group of women of reproductive age who have had first interaction with the antenatal care. There are a whole group of women of another socioeconomic class who don't have that first contact and are not able to access healthcare services. Men most times will not go and access healthcare services unless they are complicated. KP populations, gender diverse populations, people who are marginalized and have reduced right or access to services will not access the public health primary healthcare centers as easily as others. So access to service is a core entry point. Thinking about mental health and other health implications. For example, I talked about gender-based violence. In many contexts, there were stories of gender-based violence that was fatal because they were predisposing mental health conditions. We never expected the impact COVID-19 would have on psychosocial health. There were lots of evidence coming up on its impact on mental health for women, for men, for different groups of people, for children. And so thinking about what are the psychosocial impacts of either isolation for different groups of people, even older people, for different genders, that helps us integrate a psychosocial coping mechanism or psychosocial interventions into our response, which were not there in the beginning of the pandemic. Economic implications and decision-making power, that's very evident. If there are already power imbalances and gender differences, this will be exacerbated in a pandemic. And so interventions need to take that into consideration. Data, evidence, and countermeasures cannot be approached with a one blanket fits all or one size fits all approach. You cannot collect the data and community impacts without thinking about its intersectional identities, because it's not possible to develop an outreach intervention that will be tailored to all and address all the vulnerabilities we've discussed without collecting disaggregated data. Violence, I already went through it, so I won't go through it again, but violence, safety and security for key populations, gender-based violence, where there's social disruption, there will definitely be attacks around KP populations. Some of those considerations have to be taken into account when thinking through. Again, this is something that Rachel and the team have outlined in their considerations document, which I'm very excited to know will be launched. So some of these things I already mentioned with examples, but this is just to give a framework for thinking through entry points. How do I advocate? What do I start with? How does gender and human rights affect all these different issues? To the next slide, please. Now, UN Women, in preparing this presentation, we're looking through what are good examples, and also, so we found UN Women and UNDP actually tracked a lot of gender-sensitive responsive measures during the COVID-19 pandemic that were led by national governments. So they existed and there were some of them there. And I'm happy to send the link later. When the PowerPoint is sent, I'll make sure I share it with everyone. I'll make sure there's a link. But these are some examples. For example, social protection measures, labor market measures, fiscal economic measures, violence against women measures. There were 4,968. Now, when you read through that report, this is 4,968 out of thousands of policies that were done globally across the world. And then you see that very few out of that target or prioritize female-dominated occupations or target female-dominated sectors. Very few also address violence against women, which were rampant. There were 853 that addressed, but that was globally. So not enough, and address women's economic security and unpaid care. So these are some examples to show of the kind of policies, and that document, when you reach, is very helpful in kind of thinking through who was in the room making some of these decisions. And so now we've talked about, the first slide. We've talked about some examples. Now we can go to the next slide now. Now, I strongly believe, like, in times of trouble, there's always innovation. Communities know how to innovate. Communities know how to adapt and respond. And so in preparing this, we're thinking through, so when did it work? When did people do things differently? And we're able to, even in that difficult context, be able to mitigate, think of new strategies, innovate, and address some of the challenges. So one of the case studies is from Namibia. RJ, I'm just checking with you. Please let me know how much more time I have, so I make sure I'm running on time. You can put it in the chat, so I'll know as well. But in Namibia, for example, there's a link to the WHO Namibia report, so you can read it. It's hyperlinked here and read more about it. But this is just a wonderful strategy. They realized that antenatal care uptake and also immunization uptake dropped. Of course, it's a pandemic and people are isolated. Groups of people that would have not even gone to the antenatal care clinic without some sort of advocacy and support, their ability to go was further affected because of the social isolation measures. Health facilities were far and were closed, and the redistribution of allocation of services and resources to emergency response to COVID-19 meant that reproductive, maternal, neonatal, adolescent, and child health, the services went down and were not resourced. So WHO and the government of Namibia realized this, and they immediately developed interventions. Their interventions were multi-pronged, and I would encourage you, if this is something you work on, to read that report because it was really interesting. They worked on health community workers. They worked on primary healthcare centers with health community workers. They trained them. They identified, thinking through, do we need more female community health workers? Do we need to train them? Do we need them to go to rural communities that cannot access the primary healthcare centers? Do we need to do home-to-home visits? So that kind of nuanced thought, thinking through, that was relevant for the context, relevant for Namibia, relevant for the districts that they were working with. They worked with primary healthcare centers, delivered incubators, trained primary healthcare centers on non-discriminatory service provision, did health promotion and education outreach services to the communities and districts that were affected, and then talked about integrating services. How can I ensure if this woman comes in today that she's able to have access to antenatal care and immunization care for her and her children? Now, this kind of approach, which is comprehensive and multi-pronged, because it was thinking, who was affected? How do I get them here? So multi-pronged, comprehensive approaches and responses resulted in an uptake of services and was able to address the gap that was created by the pandemic in Namibia. So I'll go to the next presentation, the next case study. Now, this is about South Africa, and I thought it was really interesting because it focuses on key populations. So there were lots of PEPFAR-supported key population programs, and that were focused on female sex workers, men who have sex with men, and transgender women. And so, of course, these are populations that can't access public health centers, usually access treatment and support from drop-in centers. And when the pandemic happened, there was isolation and closure of some of these services. So there was a decline. There was a drop. I like this because it's actually a published paper that actually shows you the diagrams and the decline and the drops. And so if you can read it, it's hyperlinked as well in the presentation. And so what happened was that the communities innovated. The implementers thought through, what can we do differently? And I like this example because it didn't necessarily have huge cash inflow like Namibia did. It was really working with what we have. And so the implementers shifted to virtual clinics where possible, bulk SMS approaches to notify people, this is your time to come to the clinic when it's safe, because you had to come with appointments. The new transgender women were ostracized and were isolated in their communities. So they thought they need shelters. And if they are at shelters, we need to go and meet them because there's stigma and they're isolated. They also knew, if I'm a female sex worker, there's no way I'm going to be able to, number one, have any kind of make any money during the pandemic with isolation, have access to my clients, or have alternative means of income. And so they thought about livelihood and protection in the way they could, which was simple things like food parcels. These people are going to be hungry. These people are not going to have access to an income. Let's give them food in addition to whatever testing or drug delivery service we are providing. And for men who have sex with men, there were the community and the implementers thought through together how to identify ambassadors among these groups that went to different places and tried to think about, what do I need? What do these groups need? These are some examples. When you read the paper, there are more examples of this, but It's a wonderful case study because initially, despite the drop, afterwards, it went back to pre-pandemic levels because the community innovated, because the implementers thought, how can we help the people we want to serve, and thought through different approaches that could be used. So this is an example. And then I will go to the next one, which is a bit more global, which just takes multiple examples. Again, if you read the reference document, there are many more case study examples from different countries, from UNHCR, which focuses on refugees and internally displaced populations. So, for example, in Zimbabwe, they had a dialogue session, a community dialogue session. There was a pandemic. It was difficult to address everything, so they got the communities as a group and tried to think about, there's gender-based violence. How do we deal with it as a community? What kind of behavioral change interventions do we need to have to make a difference? And it was agreed upon together with the community. In Egypt, I talk a lot about social and economic disruption and how it makes people more vulnerable, for example, women and girls. So they developed a cash assistance project that were given to gender-based violence survivors and those at high risk of GBV to help with some of the issues around power and socioeconomic and vulnerability. And that was part of the case management response. In others, they continued, like in Iraq, they continued to deliver protection and support and cash assistance to support groups of people. Now, this is some of the examples. I'm looking forward to reflections from you. But before I end and we go to the reflection, I also want to say that the COPPA team has also been doing a lot of work in thinking through how can communities track some of these issues. And they're developing a scorecard, which I'm sure Rachel or another member of the team will go into more detail with, and we'll share that with you soon. But that is also a great example of how communities can innovate and track what is happening with them within their communities as part of the pandemic response. So I'll stop now, and I'm happy to have some time to go back and forth and learn from you and also reflect on other strategies or other issues around gender and human rights considerations in PPR. Thank you.
Thank you. Thank you, Emilomo. I think the participants really appreciated the very clear explanation as well as the case studies that you presented. And just to highlight some of the points that she made, she gave us a framework on how to understand intersectionality. So now we know that our different identities that each of us have actually influences the power and privilege that we exercise with other people. And definitely it has disproportionate effects on women. But she also mentioned that there are examples that it also takes a toll on men. And I think if we're talking about people of diverse SOGIs, they will also have a different experience. And I think all of those should be considered in policy and programming efforts. And she cited several case studies that actually exemplify that. And now we have a lot of possible entry points on how to actually integrate gender in our plans and activities. So thank you, Emilomo, for that very comprehensive discussion. So now I'd like to turn it over to Rachel so that she can actually introduce the community guides that ACT Africa has developed. So over to you, Rachel.
Thank you, RJ. Whilst I'm waiting for my slides.
Yeah, one moment.
Yes, I'd like to say that today marks a crucial step for us in strengthening our collective resilience, and we are proud to introduce this compendium of community guides for pandemic preparedness and response. This guide or this compendium is an essential resource for communities, for use of by civil society organizations, individuals, and even local leaders. And so this compendium draws on experiences, insights, and lessons learned from communities around the world, offering practical advice, strategies, and tools that can make a tangible difference times of crisis. And so it is our hope that it serves as a tool to build stronger, more resilient society where the health and well-being of all are prioritized. Next slide, please, Archie. And so currently, this compendium contains 4 community guides, which are 1 on pandemic preparedness and response. The second one is on gender equality and human rights in PPR. Third one being PPR and antimicrobial resistance. And then the fourth one is on the pandemic accord, and just understanding the pandemic accord. But that is to say that these are not the only community guides that the compendium is going to contain. So next slide. Okay, so all these would be coming up, would be launching these various guides in the coming months. So we would have a guide on PPR and universal health coverage, climate justice and PPR, community engagement in PPR, lessons from HIV, TB, and malaria, a community guide on engaging in JEE, NAPS, and SPA. So JEE, NAPS, and SPA basically are the pandemic processes that occur at the national level. We will also have 3 community guides from the Copper CLM team, where they'll be delving into PPR advocacy entry points, PPR budget tracking, and then CLM integration guide. On this note, I think I would like to take the opportunity to introduce our consultant who worked on the Gender Community Guide, Professor Sheku, who played a pivotal role in preparing the community guide on gender and human rights. He will take us through some of the key insights of the guide, shedding light on its relevance, practical application, and how it can empower communities to champion gender equity and human rights in PPR. Please help me welcome Ernest to take us through it. Over to you, Ernest. Thanks.
Yeah, thank you very much, Rachel, for that introduction. Also, thank you very much, Emilio, the first presenter, for that wonderful insight. I think it couldn't have come earlier or even better. I think the time is just appropriate how she dealt deep into some of the key things that we considered in developing this tool. So thank you very much for that comprehensive note. It makes my work much easier because then I do not have to re-echo some of the things that has already been highlighted. So this guide looks at gender equality, human rights, and PPR community guide. Can we go to the next slide? My name is Ernest Achekwa, as has already been introduced. I'm an epidemiologist by profession, but then I've worked a lot in pandemic preparedness and response, both in Ghana and internationally, other African countries. And I also consult for Africa CDC and African Field Epidemiology Network, Oxford University, and other places in working relation to pandemic responses. So this guide actually looks at 3 major areas, which will look at the background, which we are going to delve deep into. It's the importance of prioritizing gender equality and human rights and PPR, which are already been highlighted by the first speaker. And then also addressing the gender and human rights issues during pandemic. So this was more like, what can we do in this time? So let's go to the next slide whilst we look into deep issues. Yeah. So I think you all agree with me also from the previous speaker and the things we've heard so far that gender equality, human rights issues are very critical. And I always say that the next pandemic is just some seconds away from it, because now our human interaction with animals are more, and therefore it is expected that because of that cross interaction, we are going to get a lot more diseases and some viruses that will be new and maybe stronger or resilient to some of the defenses we already have. So we expect that pandemics are going to go high or are going to occur more frequently than it used to be. Also, if you pick the pandemic that we are more or less like dealt with, but still hanging around, like COVID, for instance, there is still evidence that the virus can also mutate, change, and then become deadly once more, and then all of us will have to run. And that makes this guide very important and very critical at this material moment, because we really need to make sure that when the next pandemic comes, which is just a second away, we are more than prepared, ready to deal with some of these issues, and especially, most importantly, what happens at the community level, which is the most important thing. So we looked at key definitions and concepts, where we looked at gender, we look at gender equality, human rights, and then we also look at some of the disparities that occur. And as already explained by the first presenter, that human vulnerabilities to diseases are not uniform. They actually vary from place to place, from time to time, and then also from persons to persons. And therefore, it is critical that we take into consideration everything that is contained in that. So this aspect looked at some of the disparities in vulnerabilities in terms of our gender roles that they play, especially women, the role they take as caregivers when there are sicknesses and all that. And this places them in a very special corner to be vulnerable to certain diseases, and which needs to be considered when taking some of these things. We also looked at this issue concerning disparities in vulnerability, also looked at other aspects of vulnerabilities that looked at not necessarily just women, but also looked at children and other vulnerable groups, as well as gender diverse groups within that. And also looked at the fact that it has certain influences. Then we also looked at some of the key components of gender equality and human rights. And then if you look at the map that we have out there, it talks about the right to healthcare, right to adequate standard of living, freedom of movement, freedom from discrimination and all that. So these are the key human rights issues that people have to get with. But sometimes pandemics, try to cripple some of these things. And we think that it is good that we build some of these community guides to form as, first of all, to educate people on it, and also become an advocacy tool for us to be able to deal with it. All right, let's go to the next slide. All right, so the next section of the community guide also looks at why is it important to prioritize gender equality, human rights, and PPR. Why is it actually important? Like we spoke about the vulnerabilities, but one of the key reasons why we wanted to look at it is because of the gender-based violence that evidence have suggested that during pandemics, it increases, some due to the fact that sometimes people are also trapped with people that they do not want to stay with because of this lockdown measures and all that. So some of these implications are highlighted in the document, and they are more detailed into how these issues arise as a result of pandemic responses. And we use case studies to really document these things so that it becomes more acceptable to and more realistic to all of us. Also, one of the key areas that this document touch on is economic disparity. That also occurs. In most of our settings, some of the major responsibility of taking care of our kids and all those things sometimes rest on also the women and all that, and who are mostly also kind of working in areas like the markets and all those other jobs. And when pandemic response occurred, if you pick Ghana, for instance, one of the key things that we did, the immediate thing we did, was to reduce public interaction. And to do that was to close down marketplaces and all that, which renders people, income would obviously go down, because once there is a reduction in some of these workplace related issues, like close down of the market and some of the major workplaces, which mostly evidence have suggested that is dominated by women. When they are closed down, then it means that it places economic hardship on these people. And therefore, it is good that we consider that from the beginning and use this as an advocacy to be able to deal with it. Because if you don't put it in as part of the pandemic preparedness and response plan, then during the implementation phase, it is going to be very difficult. Like I told you, if you look at my background, I've been involved in preparing pandemic response plans across Africa and in certain areas. And I know that some of these things, sometimes when they are not spoken through, they are often overlooked and becomes an afterthought. And we find it very difficult to now fit in the implementation. Also, there are a lot of these health inequalities that also exist during a pandemic, especially, if you look at COVID-19, for instance, in Ghana, let me use Ghana as an example. The total number of deaths that were reported were, I think, about 1,400. We all know, I use the word reported because it is possible that some of the cases may not have been reported. But if you compare that number to the number of people that dies from malaria, number of people that die from other medical conditions, you would, like per year, you would realize that even accidents alone will tell you that if you pick TB and other diseases, then it will tell you that the priority could have also been looked at some of these other diseases, because in fact, the number of deaths recorded among these people are much higher than even in COVID. But you realize that the attention that was pushed to COVID was so high, and that everybody was paying much attention to COVID, all the resources went to it. And that resulted in some of the other diseases that are also very important, losing its grips on the finance and also some of the resources that are available. And even in some cases, some resources that were allocated for HIV activities and other activities were rechanneled to support COVID responses and all those things, which in my case, I think affected these inequalities. One of the key things is also, sorry, okay. All right, so, and then we also look at discriminations at the healthcare and all that. For some of the discriminations, we have documented evidence to suggest in the book where you can look at, but I also look at it from a point of when there are no laws or policies against something, then that becomes, there is always like a wide way or a gateway for people to use their own discretion and project their standards or what they want onto the people. And when that happens, especially in pandemic, it affects the response measures, adherence, and other issues. Also, educational inequalities, like during the COVID pandemic, where we had to shut down schools and all that. And we realized that even during the time that they had to go back, a lot of dropouts were also experienced among ladies, especially in Ghana. A study that was conducted in Volta region by UNICEF also reviewed some of these things, that some of them were pregnant and couldn't return to school, whilst others also had other certain challenges that prevented them from going back to school. So these are some of the things. Also, the rights of some marginalized groups, and then that were also exacerbated by the pandemic's response measures that also occur. And then the document also looks at the pandemic effect on gender diverse communities, and also its impact on specialized groups like sex workers, among others, were also impacted by this. So if you go into the document, the guide, you will see that some of these things have been highlighted with evidence to really tell you how it impacted sex work activities, as well as also gender diverse communities within these groups. Next slide, please. So we now looked at what are the key things we can do to remedy some of these things. And I've already indicated that I think that one of the things that need to be done is advocacy. And with this advocacy, you need a lot of information. And I think that this advocacy must be done at the beginning, even when the pandemic has not erupted. Because you see, in most cases, the pandemic response plans are developed before the pandemic occurs. So in peacetime, we start developing the pandemic guidelines and all those things. It is during the pandemic, we made just some few modifications to suit the current situation. So I think that one of the key things that should be done during the advocacy is to start them early. So the key thing that we need to do is to map out some of the communities, and then so that we identify the vulnerable and the population at risk, because it is very good. Once we have that particular information available, then it becomes very easy to now advocate and talk about it. And then one of the key things that we think that must also be considered, which is also extensively dealt with in the document, is also the conduction of needs assessments, because now you have identified the vulnerable groups, but then what are the needs of these vulnerable groups? And we have documented how to conduct some of these needs assessments and be able to identify some of the key things, and so that it can be included in the policy. And then also community-led monitoring, which is also very important, because you see, even after pandemics, we have what we call after action reviews and other reviews that come in. And we need to document evidence of some of these things that we talk about, issues relating to gender equality and then human rights violations and all that need to be identified, need to be monitored over time and documented. And all these experiences that will be documented will be very influential in our next plan, and also even could be integrated into the current plan and be able to respond to them, obviously. And these are key things that need to be considered, and we have dealt with them extensively in the documents. And I know that it will, most of you will have access to these documents very soon. So we can go to the next slide. All right. So we think that once you have all this information, it is important to initiate some form of advocacy for the healthcare to integrate gender, human rights, HIV, TB, malaria, and NCDs all into pandemic preparedness and response plan. Like I told you that if you look at the number of deaths that are recorded by malaria and compared to the number of deaths that were recorded by COVID in Ghana, for instance, you realize that the priorities sometimes you have to be modified. But then we are not saying that, or we are not placing less emphasis on some of the pandemic, but we are saying that as far as we have this pandemic, we should also be mindful of the fact that there are other conditions that exist and needs also attention. And to be able to do that means that there should be a balance from the beginning included from that. And that means that we must advocate for these things to be included at the initial phase of the preparation. And that's why it is important that these things are also done. Then we also talk about networking, that it is important to also form and strengthen existing peer support networks, so that we build the networks, we have the support of other network, and also peer groups that will champion the agenda that we have or what we want to do, because a single group will not be able to get all these things in there, because one CSO or one organization may be involved in the other, and then one will be involved in the other. But when there is a network, then we can easily collaborate to be able to support. We can also borrow information from one network to the other to be able to support. And then during pandemic, for instance, maybe organization or a community that is dealing with HIV or dealing with another disease, we can leverage on their experience and all that to be able to support other pandemics and all that. Also, another key thing that this guide also talk about is also building champions, that we encourage women to take leadership position and participate in pandemic preparedness efforts. And this also starts from community engagement and PPR literacy. So we think that this document will also be used to get more people to be involved in championing PPR activities at the community level, and also improving PPR literacy at the community level. Because when the people in the community are empowered in PPR, then they will be able to take the necessary actions. They will be able to adhere to the guidelines that are even proposed by the experts. Because if people do not understand the effect, the issues and all that, it will be difficult to get them to adhere to some of them. And also engage PPR governance. So we are suggesting that this document also talk about the fact that we have to also engage at the national platforms, such as the One Health platforms and all the other platforms that are available, to talk about gender and human rights issues and how it can be integrated into the response to be able to generate a very good response measures that is expected. Next slide. Yes, so from this book, we expect that at the end of the day, people will have a very wide view of how these issues interrelate and affect pandemic response, and how we'll be able to better prepare and then manage pandemics. And like I told you, that this document could not have come at a better time than this, because the time that we are in currently, we expect that pandemics and disease outbreaks are going to occur more frequently, and then we should be better prepared to deal with some of these issues. So thank you very much for allowing me to introduce this document to you. I am sure that the details of some of these documents will be provided as you have access to them. And then if there is any question regarding certain areas that you want me to touch on, I'll be more than willing to do that. Thank you.
Thank you very much, Ernest. So RJ, without wasting much time, let's put up our video to officially launch our compendium of community guide. And so that's how you can access the compendium. We are making the links available in the chat box. We are also going to share with the learning hubs so that they help with the circulation, but you can easily scan it from here. And I hope this compendium serves the purpose for which it's been done. Thank you very much, and over to you, RJ.
Thank you, Rachel and Ernest, for presenting us with the compendium. And of course, for our participants here, please do scan the QR code, and it will lead you to the platform where you will download the compendium. And of course, we will be sharing the material after this session, including the recording of the session. So now, may I invite Ernest as well as Emilomo to join us in this Q&A. So I think if you have questions, they're also very willing to share their insights on those questions. All right, so anyone who has questions? And I also see here that Francis already placed the link of the compendium in the chat. So you can just click on it directly, and it will lead you to the Act Africa website. Any question from our participants? But do we have Emilomo and Ernest here already? For the...
Yes, I'm here.
All right. Okay, so I see here Martha raising her hand. Would you like to unmute and ask your question?
Yes. Good morning, afternoon, or evening to everyone. Thank you for the mouthful presentations. Really a lot to learn, and a big thank you to the presenters and also the organizers. So I have a question on our role as, civil society, but broader communities. How best can we effectively engage the government and the private sector as allies, but also to best understand and also appreciate gender and human rights and all the intersecting components around it. And I say this because oftentimes in the civic space that we operate in, there seems to be a kind of misunderstanding, when we talk about gender broadly and all this encompasses, but also when we talk about human rights, people then assume that we are pushing for immorality, we are asserting the visibility of the LGBTI community, or even the visibility of sex workers, who many would want to perceive that these are immoral people. But also coming from a space whereby very many people want to believe that this is a shutdown of, conservative ideas that we know at the heart of enhancing morality for communities. And I say this because coming from Africa as a continent where all these similarities are. So maybe back to you, the presenters. how best can we really lobby, push, but also really talk about this, these conversations to encourage appreciation, but also build allyship. Thank you.
Wow. Martha, I think that's a very complex question and also very grounded on our realities now where conservatism is actually gaining ground. So probably I see Amilomo nodding. So maybe you would like to take the first shot on this.
Yes, can you hear me?
Yeah.
Without the echo. Okay, great. I'm sorry about that. Martha, excellent questions, and very relevant for the context we are in right now. I'm going to start, but I also welcome my colleagues, Ernest and Rachel, to jump in. What you say is true. We do have more backlash against gender, and in many contexts, and I understand what you mean by saying in some sub-Saharan African context, speaking with policymakers about gender is often considered a bad thing. And I would say the approach will depend on the audience. I'm also very careful about giving recommendations that might not be applicable depending on who you're talking to. And I think the first thing is who is the stakeholder you're addressing? Are you talking directly up to like a state minister, a policymaker? Are you talking to a district health authority? Are you talking to a health service provider? Are you talking to a community leader in a local government area? Because number one, the person you're talking to is going to make a big difference in the kind of approach and language you use. The second thing is language. We like to believe that most people understand the implications of not accessing healthcare for any kind of population and the impact it will have on the people around them, irrespective of sexual orientation or gender or sex. We like to assume most people want the best for their community. And I think in identifying who you're speaking to and the right language to use and the right approach, we're able to tackle some of these issues. So, for example, in some context, people have shifted to the right to health, for example. So, having a conversation about gender, you might not go into that conversation defining gender because the person, depending on their exposure or level of knowledge, might not understand what you mean by gender. And sometimes I'm talking from a community perspective, sometimes a case study, an example of your daughter or your aunt has this problem because of this. Do you think it's something we need to engage with? And how do we engage with in a way that is nuanced and responsive to the culture that we are in? Ernest gave an example of using a champion. So, for example, maybe we are not the ones to deliver the message. Maybe there's a respected leader within that community who is an ally, who is the person who should be delivering that message on behalf of us, and using the right term and levers to advocate for it. Another example, and this actually comes from Nigeria during the COVID period, was with policymakers in the northern part of the country. There was a coalition group formed. And this coalition group included not only community advocates working in civil society organizations that were focused on public health, but also the media, so media advocates. So the coalition was multidisciplinary. So it had beneficiaries, sex workers, KP populations, policymakers who were allies, a media rights group, and then their approach was to identify which language was more relevant for the people they were speaking with. The media propagated the kind of social images they wanted to show, highlighting some of the challenges with not targeting specific populations. The policymakers who were allies knew what kind of language they had to use for what kind of bill, for whatever kind of meeting they had to have. And the advocates and civil society organizations were able to have outreach for beneficiaries. The key thing is we cannot do it alone. And sometimes we need to work with multidisciplinary teams to find a way to use the right message in the right space that pushes and advances our agenda, even more now. So again, I know that might not be a specific answer, but I'm just using examples that I have, and I'm happy to reflect more. And I invite my other colleagues, Global Fund colleagues, Ernest, Rachel, to chime in as well. Thank you.
Yeah, and I see Martha doing a heart sign, so I think she I loved your answer. Ernest, would you like to chime in?
Yeah, I think thank you very much for the question. I think there will be no one side fit all answer for her. But I think one of the key things that this community guide also talks about, apart from the building of champions, is also using community networks. Because one thing is that let me use Ghana, for instance. There was an organization that was working a lot in the area of sex workers and then other gender diverse group, which is a West African program to combat AIDS and STIs. I think I even worked with them earlier in my earlier career. And then these are already organizations, and there are other organizations who are already working in that area and have already extensive collaboration with the government. So during pandemics, and we need to advocate for some of these interventions to be integrated, it is good to also work it through organizations that are already working in that area, that has already built the connection with with the government, so that it becomes so easy to get in there. So it is very good that we use the networks. But I also agree with my earlier presenter who says that yes, using the champions is also very important, and also the kind of language that will be more or less like accepted per the stakeholder that you are going to deal with. So, and I think that the last point I want to add also is by documenting some of the experiences so that you can use that for advocacy, because sometimes without evidence, it's difficult to really talk about some of these things. But if you're able to document them well, in sometimes some people may not be very conversant with reading long essays and all that. But if they are short, especially even if they are short video of evidence of what people have experienced in those areas, then that could form a very good advocacy tool to be able to get some of these things in. Thank you very much.
Yeah, thank you, Ernest, for that answer. And what I'm picking up from Emilomo and Ernest is that one, we have to understand who we're trying to talk to, who is our main target audience for our advocacy. And then second, we have to understand the different levers that we have. It might be a local champion, it might be a network or a coalition that are already working on the ground. And third is the importance of evidence. I also see here Olive mentioning the importance of community-led monitoring mechanisms. And this is actually related to our previous webinar. We talked about health equity in the previous webinar, and they also demonstrated the importance of tools in advancing their advocacy. And then fourth, which is also I'd like to further pick up on Emilomo and Ernest on this, is the importance of reframing conversations of gender and directing it towards something more palatable or at least more acceptable to people who might have differing views on gender. And I remember when the issue of USAID is actually very very rampant. For example, in LinkedIn, I saw a list. I saw a document saying that these are the things that you or the terms that you should avoid if you want to make your proposal viable. So I think that's where a part of the conversation is happening, because some would also assert that that might not always be a good strategy, since it might actually further normalize the removal of gender conversations in the topic. So of course it might get us into our objective of getting the funding, but at the same time, it might actually contribute to the further marginalization of the concept of gender. So I'd like to hear your reaction to that. Because I distinctly remember there was a LinkedIn post um, that shared the list of terms that should be avoided. So, Emiloma or Ernest?
Okay. Sorry. So when I say using terms that people understand, that does not to clarify, that doesn't mean we shouldn't use gender, and that doesn't mean we shouldn't continue to talk about, because gender and human rights approaches are essential to delivering health outcomes, including core to pandemic preparedness response. And also, so that's not what we are saying. But what we are saying is that, for example, I have a gender background. Some people here have a gender background. If I go into a room with technical experts and I just say gender, I mean, a lot of people here understand. But if you're talking to someone who for them does not know the distinction between gender and sex, does not have the same background, you have to ask yourself, what kind of explanation makes the most sense to them? And that's where you take a step back from a more technical approach to saying, if I'm talking, depending on the stakeholder, if I'm talking to a stakeholder who works in a district health service authority, a community leader, maybe I just need to tell a story. That's what I mean. So those are two different things about not using a term, and the second one about knowing the story to tell to the right audience so that you can get to the heart of the matter, which is about accessing health care services for all populations, including marginalized populations. And I think that storytelling, narrative, collection of data, use of scorecards, identifying where you can engage people, and doing that with other stakeholders. You can't do this by yourself. There's some other people who have better ways of telling stories, better narratives, know the context more. Collaborating can help us, not all the time, but can help us pass the message in a way that people can understand and be engaged with. So that's just to clarify, that's what that means. Yeah.
Thank you, Emilomo, for that. So basically, we cannot separate or remove gender conversations from health. And I think I also agree with what Karine mentioned here. So we just build on and highlight the common ground and highlighting the importance of health for all. So thank you. And someone was mentioning that they're having issues with the audio. Is someone else having similar issues? So please let us know on the chat just so we can address it.
No issue here.
Okay. Thank you, Karine. Okay. Audio seems fine. Great. So I think we can proceed.
It's perfect. We're in Kenya and it's very perfect. Maybe he was using.
Sorry. Please go ahead. Okay, so if not, we please let us know if there are issues with the audio on the chat. Earlier I saw Collins raise his hand. Would you still want to ask your question, Colin? Oh, I see Olive raising her hand. We can go to Olive first, and then Collins, let us know if you want to ask your question. Go ahead, Olive, please.
Thank you so much, RJ. I would want to also appreciate the two presenters, Emilomo and Ernest, and also Rachel for taking us through gender and human rights and pandemics. This is a question to everyone here. I just wanted to, not to the presenters, but to everyone here, especially knowing that we have civil society and communities, and they have the experience from COVID, Ebola, and currently some of them are even working on JEEs, NAPS processes, SPA processes. In terms of gender, what are some of the key things that we should be doing that is not yet being done? Or any example, a good practice you've seen out there around gender mainstreaming or gender, Emilomo knows the words better than I do, but making sure that gender considerations are being made, especially as we prepare for any future pandemics. I would want us to open up and just hear more from the participants here. Please, if you can just suggest. Over to you, back to you, RJ.
Yeah, so please raise your hand if you want to share your experiences. After all, this is a collaborative learning space. So the learning is not just from Emilomo or Ernest or Olive. So we also want to highlight local experiences because we know that you're the ones working directly in your specific countries, and there might be experiences in your country that might not be consistent for a good thing, right? Because there are local considerations to be made. So please let us know if you want to share.
Maybe I'm happy to go if it's okay.
Yeah, go ahead, Karine.
I often talk about the woman. I think it's also good to leave the men talk to men. I was very impressed by a webinar that a colleague from the HIV team at the Global Fund did, and how men talk to men on HIV, how they can talk, right? They wouldn't talk to women, right? But they needed to talk to each other, and there was a way to do so. And we often forget this. That was for men talking to men about HIV. I had the same discussion on mental health. We are far more at ease to talk about mental health issues, right? And we must realize that for male, it's more difficult. It's much more difficult, and the consequence of not talking. So, for example, women, right? When we have a mental health issue, we talk about it with our friends. We talk about it. We may go for therapy. We may take some medicine, etc. Men don't. And the consequence of this is dramatic because it is a consequence on others, including domestic violence, not necessarily physical violence, but also moral violence. And also what they do to themselves, right, with the use of substances, alcohol, etc., etc. Because what they say is, first of all, they deny depression, and second, they say if there is any problem, they will deal with that. They don't need support, right? All my point is those two things is, yeah, it is about women, but it was also men that have a different way. they think very differently from me. Often I can't understand them, but also, I think it's important for them also to connect to each other and live this as a safe space for them to, with their languages, to talk. I don't know if it's relevant for, if what I'm saying is relevant for others, but that's from my experience. Thank you.
Thank you, Karine, for pointing that out. Like men might have very different lived experiences and might predispose them to certain issues. But also, I'd like to highlight that people of diverse SOGI might also have very complex experiences, which might require specific interventions that are specific to their SOGI. Anyone else who would like to share? I saw Leng Molina raise her hand earlier. Would you like to share? Or if there are questions, feel free to type it on the chat if you're shy, or you can also unmute and turn on your camera if you're comfortable. Going once, twice. Okay. If there are no more questions, I think we can proceed with oh, I saw Paul. Okay, so let's just accommodate Paul, and then we move to the next part of our session. Paul, go ahead.
Thank you very much. This is Paul Balogun from Nigeria. Thank you all to the presenters, and it was very impacting today's webinar. Part of the experience from Jana Health Foundations that we have especially in the northern side of the Nigeria. Before COVID-19, many women were like, we want to meet with our husband. We want them to be at home always. But during the COVID-19, so many were like, this thing is getting much on us. The attentions of men are getting much, where it actually leads to some kind of domestic violence. Some women, especially, they were not being able to become free. Anything they are doing at home, they will be asked of. So they feel like their right has been restricted, certain kind of level. So one of the things that we are currently trying to do is to see how we can bring the public health sector together with the Ministry of Women Affairs into one coalition where the Ministry of Women, the next person from the gender of the Ministry of Women will also be part of the surveillance group, so that in terms of, let there be integration in terms of any other pandemic in the future. So there will be a kind of collaboration, callings and informations will come from the same platform. So these are some of the things we're trying to look here. Thank you, and over.
Thank you, Paul, for that suggestion. So basically, bringing everyone in the platform, in the same platforms that we have. Would you like to react to that, Emilomo, or we're good to proceed?
No, please proceed. I think that that sounds like both reflections. Also the one about peer support, men to men. Also people of gender diverse populations having peer outreaches makes a lot of sense. I agree with you. And also what you said, Paul, about bringing everyone to the table. Definitely an approach that we should champion and encourage. So thank you all. Great learning reflections for us to take on board and listen to. Thank you.
Thank you, Emilio. And of course, as with our previous sessions, we'd like to take the discussion beyond this webinar. So if you have specific takeaways that you want to raise, you can put it on our chat. But for now, I'd like to thank Emilomo Ogbe for sharing her time and speaking to us about PPR and gender equality and human rights. So let's give her a round of applause. So you can use the clap function, or you can also unmute if you want. Thank you, Dr. Emilomo. And I'd like to also thank Ernest Acharieko for sharing the community guide on gender and human rights. So let's give him a round of applause as well. And if you can show your photo, your faces by turning on your camera, we'd like to take a photo with our speakers just before we end the session. So Mook, can you take on your can you take the photo?
Yes.
Yeah.
I would love everyone to turn on the camera if you can. So I'm gonna count on 3, 2, 1, and then smile. Okay. Thank you very much. Over to you, RJ.
Thank you, Mook. And as before, we have an evaluation form. So hopefully you can answer the evaluation so that we can improve how we conduct sessions. You can scan this QR code, or you can also click on this link. And if you want to receive the copy of the presentations, please do answer the evaluation form so that we can get your email address. And you can also follow Apcaso on social media. So we usually post updates there. So you just go to Apcaso on Facebook, and then you can also go to _Apcaso on Instagram. Oops. Sorry, I clicked it and it led me to the Instagram page. So yeah, and then I also invite everyone to join the WhatsApp community group so that you can be updated on announcements and then also the conversations. So I think that's the last slide. So I'll turn it back to the evaluation form. But thank you for attending. Thank you to Emilomo, to Ernest, to Rachel for helping us coordinate, our friends from the Global Fund, and of course our translators in French, Khmer, and Bahasa for joining us this evening. And of course, to our participants, thank you for joining us in the sixth lessons webinar. All right. Goodbye, everyone.
Thank you, RJ.
Thank you. So once you already answered the evaluation form, you can already leave. So we'll be closing the webinar in a few minutes. Thank you. So we'll just wait for 2 more minutes and then we'll start closing the link or putting you in the waiting room. Thank you, everyone. Thank you, Joanne. Thank you, Anne. For the WhatsApp group, you can you can scan this QR code on the right. Okay, so we'll be putting people in the waiting room now.
Oops. I think I can also create a breakout.
Yeah, I think so, so that we can continue with the meeting. Thank you so for thinking about that. Yeah.
Okay, let's just do that. We're manually moving people to the waiting room.
Some of them may have left.
Yeah, I think we're just the one. Okay.
You know, some of them are coming back to the main group, yeah?
I think for the main room, we're just us.
Okay, okay.
We moved them to the waiting room.
Perfect. All right. Congrats again, RJ and everybody. Oh, we didn't have Emily.